Hey everyone, and today on your Applied Bacteriology lecture series we'll be talking about clostridioides difficile. The learning objectives for the clostridioides difficile section include the following. Be able to discuss initial management of mild and severe infections, describe strategies and considerations for infection control, and be able to differentiate between management of initial clostridial difficile infection and recurrence. We will start by reviewing the microbiology of clostridioides difficile. It's an obligate anaerobe, spore-forming gram-positive rod. It has 3 virulence factors, 2 are exotoxins, and 1's a binary toxin. Exotoxin A binds to the brush border enzymes on the intestinal wall, causing local inflammation resulting in that watery diarrhea. Exotoxin B actually disrupts the cytoskeleton integrity, leading to enterocyte cell death, resulting in the classic pseudomembrane, which is that yellowish-gray exudate that would appear on gross examination if you were to perform a colonoscopy. The binary toxin has an unclear role, but theories believe this acts synergistically with the exotoxin, causing severe colitis. Case 1. A 78-year-old male with chronic obstructive pulmonary disease is in a skilled nursing facility for rehabilitation following hospitalization for pneumonia. He complains of persistent chest pain and pressure unrelieved by antacids and is sent to the emergency department. Because of a positive urinalysis, the ED physician starts the resident on ciprofloxacin. He has a positive troponin and is admitted to the hospital for a myocardial infarction. After 2 days, the resident transfers back to the skilled nursing facility. You stop the ciprofloxacin and continue the new beta blocker and ACE inhibitor. 4 days later, he alerts the night shift that he has loose stools. When you go see him around 10 a.m. the following morning, he has already been to the bathroom 5 times. You suspect Clostridium difficile infection. What are your next steps in managing this resident's diarrhea? The patient presented in the previous case likely has an active Clostridium difficile infection. When suspicious of a CDiff infection, ensure that you quantify the stools, that there's more than 3 over a 24-hour period, and if they are actually watery. Also take into account his risk factor of recently being on an antibiotic. So your suspicion is very high of a C. diff infection. So if you're able to stop the offending agent, stop it. Most antibiotics cause C. diff, with clindamycin and your quinolones having the stronger association. And then it's important to adequately resuscitate these patients as active diarrhea is causing severe volume loss. Stop any bowel regimen or laxatives. Send the stool sample for C. diff testing, and we'll go over how to do that in the oncoming slides. And if your clinical suspicion is high, you can empirically start treatment. Avoid any anti-motility agents as the toxin can build up and this can result in toxic megacolon. And then ensure that you employ necessary precautions to help protect surrounding patients and healthcare workers from spreading the spores to other patients. When approaching testing, first ensure the patient is having greater than 3 watery stools in 24 hours and is not actively taking laxatives. When testing for C. diff, there are 3 different tests that you can order. The glutamate dehydrogenase enzyme, and I'll refer to that as GDH, toxin A and B ELISA test, or your PCR test for the toxins. The GDH is present in all species of C. diff. It has a very high sensitivity, but its specificity is very low because it's positive in all patients with an active infection or if they're colonized. The ELISA toxin test, there's an antibody that actually identifies the toxin. If you order the GDH and the ELISA toxin and they're both positive, this patient has an active C. diff infection. However, what if only one of those tests is positive and the other is negative? Then what? This is an intermediate result, and you would perform the nucleic acid amplification test, which is the PCR test, and this is looking for the gene that encodes for the toxin. To summarize, when testing for C. diff, you want to order at least 2 different tests, the GDH, the ELISA toxins, or the PCR test. Please check with your facility about available testing, as some facilities have reflex testing that's already built into their orders. If suspicion is high, you can go ahead and place precautions on the patient prior to the test results. In doing so, you want to ensure the patient has a private room and their own bathroom. Healthcare workers should instill contact precautions when entering the room. This includes personal protective equipment, the gown, and the gloves, and this should be removed prior to exiting the room. Hand hygiene is critical as alcohol-based products do not kill the spores, and you must wash your hands with warm water and soap. It's also important to educate the patient about their hand hygiene and to ensure that they're washing their hands after each use of the bathroom. Current IDSA guidelines recommend waiting at least 48 hours after symptom resolution, i.e. the watery diarrhea, before removing the patient from these precautions. However, there is evidence out there that does suggest that these organisms can shed spores up to 7 days. You'll typically see hospitals extend the precautions throughout the patient's hospital stay just to ensure that there is no spread of the CDiff. Treatment of C. diff has evolved over the years, and the most recent up-to-date IDSA guidelines recommend PO fidaxomicin as the first-line treatment now for C. diff due to the decreased recurrence when this regimen is used. However, if it is unavailable, it is still reasonable to use your PO vancomycin. Fidaxomicin is a great drug because the bioavailability in the gut is great and it's poorly systemically absorbed, leading to minimal side effects in the body. A downfall in this medication is it's much more expensive than the vancomycin. The duration of treatment for the initial C. diff infection is 10 days regardless if you use fidaxomicin or vancomycin. The dose of fidaxomicin would be 200 milligrams PO twice daily for 10 days, or if you use the vancomycin, it would be 125 milligrams PO 4 times a day for 10 days. If the patient has another episode of C. diff, the guidelines recommend different approaches. If the initial treatment was with fidaxomicin, they recommend to try again with the same course and duration of the fidaxomicin. If the initial treatment was with PO vancomycin, they recommend now using the fidaxomicin for the recurrence. Or if fidaxomicin is unavailable, you can use a PO vancomycin pulse dose taper, and I provided an example of the taper schedule dose that they used in the trial here at the bottom of the slide. And the new guidelines also suggest using a new monoclonal antibody called bezlotoxumab. That's if the recurrence was in the first 6 months. Bezlotoxumab is a monoclonal antibody that binds to the toxin itself. I encourage you all to read the trials of this new medication. They were published in 2017. I provided a link there for the New England Journal of Medicine paper. And if you guys remember that back in the 2017 guidelines, they recommend the fecal microbiota transplant for ongoing recurrences. That's still recommended. However, just be aware that there has been increasing adverse events in the use of fecal microbiota transplant since that time. In summary, you should now understand the microbiology and the pathogenesis of the Clostridioides difficile. You should be able to test and interpret those tests for an active infection, know the precautions and the strategies to employ when a patient is infected, be able to treat and manage an initial and recurrent Clostridioides difficile infection. And as a reminder, I always recommend reading the guidelines for the most updated information and a more in-depth look at Clostridioides difficile. I've provided a link at the bottom of the slide. Thank you.